I presented a review of the impact of aging on the biology of myeloma, and I think this is really a fascinating question, because we know that the older patients are actually most of our patients with myeloma, and we know that their outcomes, unfortunately, are inferior to the younger patients. And some of these issues are to do with their frailty and with the toxicity of a treatment and compliance. But the question is there anything inherent in the myeloma itself, in the biology of the myeloma itself, that drives towards these poor outcomes? So I looked at various aspects, the tumor cells themselves, the cytogenetics, and there are various data from different trials, from the IFM trial and from the Myeloma 11 trial. But patients, older patients, do have poor cytogenetic aberrations, as do the younger, and there's a variation on the rate with different aberrations, but they're there, and the proportion of patients with poor risk cytogenetics is probably not very different. The impact of these cytogenetics, the relative impact is actually lower, but this is because of the competing risks, and not necessarily that these aberrations don't matter. There's actually interesting new data looking at things like chromotripsis, which is like a shattering of a certain area of the chromosome, and rearrangement. This tends to be higher in elderly patients and impose a worse prognosis, short tumor telomeres, something that was recently published, also related to poor prognosis. So that is the aspects of the tumor. Then I also covered the aspects to do with the immune microenvironment that we know interplays with the myeloma, and there is this phenomena of aging of the immune system and the senescence, and this affects both the innate immune system as well as the adaptive, and there are various data in myeloma showing that indeed the senescence occurs in older patients. For example, a reduction in the T cell repertoire, a shift towards a more mature T cells, and a senescence of the innate system. And so this is very relevant in this day and age because of all the immune therapies. And the question is whether these B-specific antibodies and CAR-Ts, would they work in elderly patients as well? So I looked across several of the data that have been published from the KARMA trial, from the IDA-cell, the CARTITUDE data, CARTITUDE-1 data, teclistamab data, and it appears that actually the efficacy, as far as response rates at least, is quite comparable in the older patient despite this senescence. So I think we need to wait for more mature data and to evaluate this further, but initially this seems to be encouraging.